Okay.
Hi everyone, this is our 26th Facebook Live. Welcome to it, I guess. My name is Danielle Adams. I'm a physician assistant. I'm working here at Jemsek Clinic with Dr. J, and we're going to go through a few questions here today about the indicators of a successful treatment.
Thank you, Danny, and welcome, and we're so happy to have her as a strong member of our treatment team. This is the 26th live stream, and in less than 4 years, so I'm pretty proud of that. So that's like 25 hours we've got on the shelf. And we love the questions and the interest that has been generated, and we try to answer all pertinent questions, but we do have specific topics. And this topic this month will be indicators of a successful treatment, which I think should be very interesting to almost everyone listening.
So our first question today that we're going to be going through is someone who wrote in and said, "I've been treated before, but symptoms came back. How can we avoid that in the future? And what kind of makes our treatment approach here a little different?"
So just to remind everyone, we're a destination practice, and so we see people, and we're thrilled to see people from all around the world. And many of them have had previous experiences. Sometimes one or two providers have been working with them, sometimes 24. And so they're very frustrated. But we find that the two major deficiencies, if you will, with other prior treatments has to do with adequate therapy for Babesia in conjunction with biofilm disbursement. And we'll talk about that a little bit more in the future. Danny?
And I think another thing that is a little bit different in terms of our treatment is our ultimate goal is to try and promote immune competence in our patients. And so the pulsing treatment and the way that we pulse our antibiotics kind of helps implement better immune response within our patients.
Right. Yeah, right. Mm-hmm. And it's a long journey. It takes many months. It takes probably an average of 15 months, whether you're doing oral or IV therapy. Sometimes it takes a little bit longer. But the ultimate goal is to turn over these infections to your body so that your immune system is able to deal with a decreased inflammatory load, or infection load, if you will. And that takes a while. It takes 2 or 3 years, but the bulk of the heavier treatment is done in the first 15 months.
So the next question that we have today is, how do I know that I have Lyme and will respond to treatment? So when we're considering diagnosing Lyme, we have to remember that it's primarily a clinical diagnosis, meaning it's done by a provider who is evaluating you with a comprehensive history and physical exam. And sort of the things that we're looking for are 3 core factors: is chronic relapsing symptoms that have not been explained by anything else, to include arthritis or pain, neuropathic pain or neuropathy, tingling, numbness, paresthesias, things of that nature. And then also just other issues with mood, limbic irritability, and sleep that just aren't, otherwise better explained. And lab testing can be supportive of that, but again, it's primarily a clinical diagnosis. Do you have anything to add, Dr. J?
No, just to emphasize the encephalopathic component of it. So Danny was talking about an inflamed brain on fire. And yeah, that can manifest in different ways. It can manifest depending on what lobe of the brain is being involved. But the brainstem and the limbic system, the lower part of the brain, are particularly involved, and those are all involuntary activities. So things can become quite bizarre in this disease because there's nothing to compare to it as far as the amount of inflammatory specificity it can bring to the central nervous system. And so folks are often dismissed by other providers because the symptoms tend to be bizarre. We are still learning. We're accruing new symptoms even after all these years. because of the bizarre and broad spectrum nature of this illness and its manifestations.
So a lot of patients always ask me, when can I expect to start to feel better? And I think Dr. J had a few thoughts on that.
Right, so in our experience of over almost 20 years, we know it takes several months. And I termed I didn't invent, but I coined the word blue sky days. Because people can relate to that. And most of our folks that come in don't have blue sky days. Everything's miserable. They may have a blue sky moment. And we want to see blue sky days. And it is a bit of a journey, so it takes several months of treatment where we're doing pulse therapy and giving patients time off in order to detox and preparing them by stabilizing their stress factors. So if you look at our website, you look at how we evaluate, that's followed by stabilization. That means we want to stabilize pain, we want to know that they have a good family situation and support. That's so important. We know their blood work reflects any outliers, including endocrine abnormalities. How's their mood? Is it manageable to go through this? Are we working with a psychiatrist or not? And if not, then we can treat. If we don't think we can handle the treatment for the psychiatric component, we definitely want to get someone involved. And last is sleep. So sleep is so important and overlooked. But that's the crux. There are many other criteria and other outliers, but those are the main things that we look at.
And I think just to add to that, all of the things that Dr. J was talking about is great in terms of things that we're trying to improve for patients. And those blue sky days, again, happen a little bit later in treatment, but there can be lessened symptoms if we're sort of addressing all of the issues, the sleep, pain, as he mentioned. And symptoms can become less frequent or less severe throughout treatment, but we want to kind of emphasize that progress is often nonlinear. As you're treating with antibiotics, the Herxheimer responses can cause some waxing and waning of symptoms, but overall we're looking for a general positive trajectory throughout treatment, and that's kind of the thing that we want to highlight. And then our next question is something that Dr. J wants to kind of expand on a little bit, but how do we know that treatment is working? So, I think talking a little bit more about the reactivity that can happen with treatment as a result of the Herxheimer response. Yeah. Okay,
so I'm pretty sure most people understand what a Herxheimer is. Was derived from the cousins in Austria and Bavaria in the late 19th century when they were treating syphilis with bismuth and antimony, and they would get a typical reaction with expression of skin lesions and so forth. That's Herxheimer. That happens with the spirochete family, and of course Borrelia is the head of the spirochete family, so it gets a titular nod for being the most immunocompetent immune-armed organism on the planet. But it has a lipoprotein coat as opposed to gram-negative bacteria, which have a lipopolysaccharide coat. So lipo means fat plus protein. Liposaccharide is fat plus sugars. And for whatever reason, our immune system evolved to the point that when it sees lipoprotein, it elicits a much larger response, some 20-fold. By a conservative measurement, and it's happening in the brain, and so that can be very, very destructive. And I think I wanted to follow up on one other thing that you were leading into, but we'll move on.
Mm-hmm. Yeah, so the Herxheimer responses are an indication for us that the antibiotics are promoting some immune activity and causing some die-off of bacteria. So it's a good thing, but we really want to emphasize that this should be manageable. And Herxheimer responses vary a lot patient to patient, so working with a provider is really important to kind of manage them and make sure that you're able to do everything that you need to while going through treatment. And we kind of help with this with our stabilization period. that we'll be getting into a little bit more later. And also we ease into our treatment and kind of build naturally as we go through, all designed so that people have, you know, a good response to treatment overall, regardless of the Herxheimer responses that we're seeing. And then the next thing we wanted to get into was, are there any lifestyle changes that I can implement, you know, to help myself through treatment, which is always a great question. I always have my, new patients asking me that. And there's a few different things. We really want to implement a low inflammatory lifestyle. So changing your diet to reduce gluten and sugar is really important. We talk a lot about detox, which kind of helps our patients with lowering the inflammation quotient in their body so that they're better able to handle the treatment moving forward. And, you know, it's our job to kind of guide patients as to what methods of detox are safe and the best to use. And, you know, just addressing all of the aspects of Lyme and all of the symptoms, and kind of working with the provider to find a good balance in terms of all of the things that we kind of mentioned before: pain, hormonal issues, stressors in your life, making sure you have good support. You know, all of those things are really important. Sleep, as we, you know, had an episode on before. So those are kind of lifestyle changes that people can implement. And then the next thing we wanted to talk through was, how do we make the decision to move through treatment? So we kind of graduate our treatment from Borrelia to Babesia, Bartonella. Kind of what does that timeline look like? And how do we decide when to move on to, you know, different protocols and different antibiotics?
Thank you, Danny. So we're looking for balance points, but we also know we have work to do and have a job to do, and we need to always kill the spirochete, and we look at all stages of the spirochetal life forms, which includes the wild type, which is extracellular. It can also be intracellular. The cyst, of course, the blebs, and because this is a very pervasive organism, very opportunistic organism. And once it's activated through stressors or through additional infections, it's off to the races, and the immune system playing catch up. It's a lot like COVID. With COVID patients, we're playing catch up. Once the COVID virus got past the immune system and past the adaptive immune system, the innate immune system, then the adaptive, and then the adaptive immune system is playing catch up, and that leads to the cytokine storm. It's very similar to what happens in Lyme, but obviously Lyme is a little more slow motion, but it can be devastating. And I think that our first job, a very important job if we want to set up for success, is to be honest with the patient and tell them, yes, we can stabilize you, and yes, you can have therapy. And you will be successful, but it will take quite a while, and there'll be stages of therapy. And you may not see any sustained improvement or blue sky days for several months, and that's okay. We look for indicators of improvement by clinical exam, and we're very much committed to doing an exam on each visit, which I think is so important and seldom done. We're very committed to tracking our problem list and problem areas through our dictation and notes. So we track those, and if new ones come up, we add those. So we have something I've done for years, which is intercurrent events and action items, which means, okay, what happened since you were last here? What, you know, any new events, and you know, what are the action items that we're going to do today? So we have a general plan. It's not cookie cutter, but we do have a general concept of how to approach our patients. And as Danny said, we want to start slowly and just kill a few spirochetes, and then we get into biofilm and we attack Babesia. And some of you have heard me say that I think Babesia is the driver for these infections. And why do I say that? And this is controversial, of course, but what's new? We all have Borrelia in our body, I'm convinced, almost everybody. So once you have it, you have it. That doesn't mean you're going to have Lyme disease or some dreaded infection. However, if you're genetically predisposed and you happen to accumulate the major co-infections, and you're exposed to constant stressors, major stressors, there may be a tipping point. So clinical patterns can vary quite a lot. Somebody can wax and wane over decades, and somebody can become acutely ill after a flu shot, for example. I'm not trying to scare people away from flu shots. Please don't take it that way. But any kind of antigenic stimulus may be a tipping point to where the patient gets headache and becomes acutely ill and stays ill. Danny?
Yeah, so, all of those were great points. I think kind of the through line there being that our treatment plan is individualized for the patient, and we have certain markers that we're looking out for in terms of symptom improvement or changes with the exam findings. And we kind of have to target treatment specifically per patient based on those things. Now, another question we got was, why do some patients reach long-term remission and others will get sick again and again? What sort of causes relapse? And so Dr. J kind of mentioned a few of these in terms of, extra stressors on the body can cause symptoms to sort of flare up again. A lot of these can be illness, COVID, in unexpected surgery, emotional stressors, maybe re-exposure, and those are kind of some key factors. Anything that's adding stress to the body, essentially, can predispose someone for relapse. What are we seeing when we see patients relapsing? It means it's an emergence of symptoms, and one of the ways that we try to promote more long-term remission in patients is through maintenance. So after our active treatment period, we go into a maintenance period where we're trying to assess the patient's immune response. Did we put the immune system back in the driver's seat? And as we're looking through that, we're determining, are patients maintaining their progress? Are they seeing symptoms flaring up when they're treating with antibiotics, indicating some more reactivity, maybe, more infection load? Or is their immune system kind of showing some regression and they're just unable to keep progress locked in their off weeks? So those are some things that we kind of analyze as we go through maintenance to try to course correct, essentially, so that our patients reach long-term remission more. Anything to add, Dr. J?
So just in summary, we have 4 stages to our treatment. One's induction, where we just work around the edges and see what reactivity, and that's after patient's been stabilized. So I can't emphasize enough how important it is to stabilize. Doesn't mean that sleep has to be perfect, that your psychiatric situation has to be perfect. But we need to identify stressors, and if we can't treat somebody because they have an outlying stressor that doesn't seem to be able to be corrected, then we'll just tell them we have to get this corrected before we treat you. It's not fair, and we want to have success, and we want to have success for you. So we do induction, then we get into heavier 6-month program with Babesia-based program with biofilm disbursement, which will continue throughout the next several cycles. Then we'll carry over for another 4 months or so of what we call a Bartonella-based program, where we may drop Mepron, which is a Tovaquone or Malarone. We may drop that, but continue some Babesia coverage and emphasize some Bartonella coverage. And that goes on for 4 months. And what we're looking at is the amount of reactivity during treatment and the amount of time, how long it takes to wash out. In other words, after 2 weeks of treatment, does it take a day to wash out? Does it take 3 days, 5 days, what have you? So if it takes longer, our patients obviously have problems with detoxification. And that's one of the reasons they got sick in the first place. And finally, after that, if we feel like everything's calming down, we go to a maintenance program. And then on maintenance, we talk about 3 days a month, 1 week a month, with combination of herbals and antimicrobials. And we don't want to see much reactivity. If we have a little, it's okay, but it should go away. And we know that it's a red flag if at some point after initiation of the maintenance program in the 2nd year, patients are much more reactive. So that's a red flag. And also the other factors, they can't hold on to the 3 weeks. They don't have 3 weeks of blue sky days. And that's everything else equal. Life happens. There's all kinds of things that can perturb, and COVID is by far the number one factor in the last couple of years that have thrown our patients off course. And then once they're in maintenance, we look and see if they start to become reactive on maintenance, because that's a bad sign. And we're missing something. So we look at, and we're going to post our roadblock cues, starting with poems. And if any of those things are askew, our job is then to query the patient. Okay, what's going on in their life? You know, are you sleeping? Did you go back on gluten? You know, did something else happen? Are you having other stressors? Do you have other medical conditions that are emerging? And so forth and so on. So our job is to understand what causes people to fail, and we're going to post that next week, most likely, as what we call roadblocks.
Thank you, Dr. J. So the next question that we wanted to talk through here was, how do we know what's permanent damage or symptoms that won't go away after treatment? Sometimes people ask about numbness or tingling, paresthesia. Some people ask about joint pain. So Dr. J had a few initial thoughts about that.
Well, our patients are very astute for the most part, and I have the question asked me every week, if not several times a week. Okay, am I experiencing just damaged tissue, damaged reactivity, or am I still infected? And the best way, I think, to tell that is to see how they're reacting on their maintenance program or their step-down program. And more times than not, it's residual damage that's been done, and we support the patient if it's a stressor. In other words, if you still have peripheral neuropathy pain, they need to be on something to help support that until they don't need it. If they're still having sleep disturbance, these are things that take a long time to recover and heal. So the nervous system, so I think expectations should be that on an oral program for a moderately ill but affected individual would be 2 years. 2 years of maintenance, during which time they're continuing their healthy lifestyle with low inflammatory lifestyle. They're doing positive things for activity, stretching and toning or walking, and they're able to do things that they couldn't do before, but they need to continue to do those in order to heal, because the healing process is very long. And if you're severely infected and somebody that requires infusion, for example, because the extent of your cognitive deficiencies are severe, it may take 3 years or longer to get full recovery. But I would say, you know, since we follow the patient so carefully and monitor the severity of the reactions and the identity of the reactions, if those are quite active, especially on treatment, then we know we have missed some treatment. We may want to go back and retreat. Matter of fact, Danny, this might be a good time to talk about retreatment of babesia. So I'll be happy to do that. In the last 2 years, as we follow our thousands of patients, the last 2 or 3 years, we noticed that the number one reason for relapse is an association with recrudescent babesiosis. How do we know that? Because we examine our patients on each and every visit. And one of the hallmark findings for babesiosis is a enlarged liver and a enlarged spleen. It's not universal, but quite common. If, in fact, we have a situation in which our patients had resolution of hepatosplenomegaly, in other words, their liver and spleen are back to normal size. And by the way, to those who don't know us as well, when we say enlarged liver and enlarged spleen, these are not damaged organisms, they're just congested. All right, so there's no liver failure, there's no spleen failure. But they are congested and they are enlarged, and they can be palpated and detected on exam. So if a patient is relapsing and boom, you know, they come in and we find, oh, your liver's popped up and your spleen's popped up. And that happened numerous times because, you know, not everybody stays well. And the question is, okay, did you relapse, or did something else happen, or is there some other life element that's causing you to have issues with your mood or energy? But if the liver and spleen are enlarged. That reflects babesiosis. Well, we got tired of that and seeing that. We saw it more commonly in our sicker patients. So 2 or 3 years ago, we decided, okay, we're going to get our patients to maintenance, which takes 15 months or 18 months, depending. And we're going to let them go on maintenance for 2 or 3 months. Then we're going to retreat for babesiosis, which means a cocktail of artemisia groups, atopic malarium type groups, cryptolepis, mimosa pudica, some antibiotics, et cetera, et cetera. So people that have done that with us know exactly what I'm talking about. We find, knock on wood so far, shall I knock on wood? Probably done retreatment empirically with 100 patients. Nobody's relapsed with babesia so far. So it's still early, it's about a year out, but I think it's a good strategy because the difference is that when we want to get babesia off the table early on because it blocks the immune response and it creates its own set of inflammatory markers. But when we're treating early on, in the 4th month of treatment, for example, our patient's immune system is suppressed and it's not competent. Whereas over a period of a year to follow, it becomes much more potent, much more immunocompetent. And at that point, we retreat again. So now we have an immune system helping, and the immune system should be the main feature anyway. So we think it's an excellent strategy, and we're seeing far fewer relapses on that account. Danny?
Yeah, so just awesome information about babesia there, but just kind of reiterating the difference between permanent damage and maybe damage from active infection. You know, nerve pain or arthritic pain that's a result of the infection is because there's damaged nerves or tissues. And obviously damaged or infected tissues and nerves can't heal. So once we get rid of the infection that's playing a role in that, then your body and your immune system can focus on healing. So that aspect might take a few years of healing to really see a big benefit in terms of that pain kind of going away. And as Dr. J had mentioned, maybe there's some supportive medications to help with pain management until we reach that point in that part of healing. And also, you know, maybe there's a comorbid condition like osteoarthritis as opposed to Lyme arthritis that might be playing a role too, that Lyme exacerbated. So that's always a possibility too, but I think kind of working with your provider to sort of parse out what might be going on is important if you have any other questions about that. And then the next thing we wanted to touch on is what are indicators of an unsuccessful treatment and how do we know, you know, when to stop? And I think that is something that a lot of is individualized patient to patient. And, you know, there might be some confounding factors in terms of other conditions that are playing a role or exacerbating Lyme that can make it a little more difficult to treat. So maybe that's something that needs to be addressed first. You know, what are the stressors in a patient's life that might be providing a barrier to treatment? Like Dr. J mentioned, roadblocks as we call them, and we'll be posting those on the website too for you to look over later. But those are, you know, some key components that might have to be worked through. Any other thoughts on that, Dr. J?
No, I think you said the magic word was infected tissue can't heal. And I've been saying that for years, and I explain that to the patients. And it's sometimes hard to conceptualize, okay, how can my nerves be infected? How can my spinal cord be infected, my brainstem? Well, they are, because Borrelia burgdorferi, as shown by Livingood in 2006 in New England Journal article, and it can affect any of the neuronal cells or support cells that we have in our body and brain. And so it's a sinister infection, and it causes bizarre symptoms accordingly. And so infected tissue can't heal. So if we want to get a positive response, we have to stabilize the stressors that are associated with these infections, of which there are many, starting with pain and then mood and sleep and so forth. Those are essential life functions that have to be ameliorated to some extent before we even start. So again, it's not just throwing antibiotics or antifungals or herbals at patients, saying take these and take them every day. So the reasons based on the understanding of our target organisms that we do pulsing, that we do combination therapies because we don't want resistance, that we do pauses so patients can detox. But before we even start, we do everything possible to stabilize the patient, whether they need new medication for neurotropic help, sleep medication, a list of supplements that many of which are already being taken by the patient, but we do have our first tier of supplements that we employ that are neuroprotective predominantly. And all those things have to have some improvement before we even start therapy. And so it's all about being able to purge the infected tissue, and we can't do that if the patient is under so much stress, physical and emotional and psychological stress. It's just not going to work. So so there is a process. It generally takes 4 to 6 weeks after the initial assessment for us to get data, order exams and film studies and so forth, whatever we need, before we feel like we're ready to go ahead with treatment, because now we have a better understanding of our patient situation.
And I think just to expand on that, as that sort of leads into another question we were asked about what to expect during the stabilization phase is, as you know, after our new patient visits, the provider often sort of targets whatever roadblocks that we're anticipating a patient may run into during that time, and trying to manage them. So sort of optimizing pain, sleep, stressors, etc., in a patient's life to lower symptoms. So in that stabilization phase, we're looking to kind of lower the symptom load for a patient, and lower the inflammation in their body so that they're better prepared for treatment, so that when they do experience a Herxheimer reaction, again, it's manageable and we can continue through treatment without reaching any further roadblocks down the line. So just emphasizing that.
Right. So manageability is one of our favorite words. Everything has to be manageable. Danny's perfectly appropriate in saying that things need to be manageable and stabilized before we start treatment. That's so important. It's like, okay, do you want to drive your car on the side of a mountain that's curved 45 degrees? You want to stay in the 2-lane or 4-lane, So it's just a matter of how do you want to make this journey? What's the chance for reaching the destination? I had a question come in about talking about Babesia biofilm. I would love to do that because one of the rewards of being attentive to each and every patient, each and every visit, is that you can learn things from a clinical point of view, which may take years to confirm in the scientific journals. So some years ago, I always knew about biofilm, but I didn't know how to handle it, so I used some very mild products to sort of tease it out, because I knew if I blew up the biofilm, I would torture my patients. So I didn't know how to go about that, and so I did this nitakinase for a while, and I did nothing for a while, and then I said, I have to get after the biofilm. What's the best, most efficient way? And I found a group of surgeons in Montana, surgical reconstruction group with diabetic wounds and wound infections, basically. And they had written somewhere in some little blog that I saw that they were using xylitol and lactoferrin, and I think their PhD scientist had suggested, okay, biofilm melts. Biofilm was melted by xylitol. Xylitol is a sugar alcohol, just like stevia. So we use it in a synchronized way, and so do not use stevia, please. Okay, don't just start taking stevia, because what you have to have is a coordinated program where you use biofilm in treatment, and then you kill what comes out of the biofilm. If you use biofilm constantly, you're just going to have microbial chaos. How did I find out about Babesia biofilm? Babesia biofilm. I was curious, and this was not a kind thing to do, but it was not an unkind thing to do either. I had a number of stable patients who would come in every 6 months or so. And they were fine. They were in remission. They were on minimal therapy. And I said to each and every one of them, would you be willing to take some xylitol during your treatment week just to see if there's any effect? Because I was just learning about this. And I understand that we should just do 8 grams or 2 tablespoons of the xylitol sugar and not take any stevia anytime during the month. And do it just for a few days, the first part of your treatment cycle. So I did this with 30 people or so, and as they started to recycle and come back, I would say to the first person, I remember the first person, Mr. Cower, for example, from North Carolina, I said, well, how you doing? It's been 6 months, you were doing great, you were working, you were, your brain was good, energy's good, and the patient said to me, what in the hell did you do to me? And I said, well, I'm not sure. You just took the xylitol, right? And again, by serial examination, all of a sudden, Mr. Cower had a liver and spleen enlarged, where he had not before. So then the second patient comes in, same story. The third, same story. The fourth, not so much. The fifth. 80% of the patients came in. And it's like I couldn't stop the train once I'd started the engine. But I did learn very vividly that, oh my God, I've released Babesia because I released biofilm. Babesia exists in biofilm. Therefore, it's critical in your treatment approach to take that into account and treat Babesia as if it is an inhabitant of a biofilm colony. And that was a very vivid lesson, and it holds true today, and so that's what we do. We use biofilm early in our treatment cycles, then we try to kill what comes out, and depending on where the patient is in their phase of therapy, we'll use various different medications, but Babesia definitely gets this sort of attention. Is that a good answer?
Yeah.
Is that okay?
I think so. All right, another question that we got was, how do we address the psychiatric Herxheimer responses? And I think that is again, individualized per patient, but it, depends on, what are we dealing with. A lot of our patients have psychiatric conditions that are either worsened or due to Lyme. And when we're talking about depression as one, this is something that's very common in our patient population, as it is common for people with chronic illness in general. So coming up with a plan, that initial visit with the provider and, communicating with your provider any concerns that you have about your mental health is important so that we can work, with the patient to come up with a comprehensive treatment plan, and also trying to implement, other specialists and get other people on our treatment team for the patient so that they are better able to, handle whatever psychiatric stressor might be going on, whether that's a psychiatrist or a counselor, therapist, etc. We have a list of providers that we have worked with in the past that are Lyme friendly that we like to use and let our patients know about so they can get treatment that is addressing both the psych issues that might be occurring, but also approach it from a Lyme perspective, because I do think that that's important as this is a part of, the disease. Any other thoughts on how to handle psychiatric?
Well, the neuropsychiatric component can get better, but won't necessarily heal because the damage has been done, but at least they have a chance to heal now. Because common thesis and a common belief that we share is if you have infected tissue, it won't heal. And that includes the brain and the circuitry in the brain and the spinal cord and other areas of the body. If the tissue is infected, including the neural sheaths and neural pathways, it will not heal. And so we emphasize to our patient, okay, we're going to manage your psychiatric or sleep issues or both, or working with a psychiatrist or psychologist or not. And just understand, you're in the process of purging these infections so that in the future you'll have the opportunity to heal.
Another question we wanted to go through was, does the immune system take care of the infections by itself after a certain point? And the answer to that is yes, that's our goal. Through treatment, what we're trying to do is bring down the infection load in your body, but also promote immunocompetency so that patients are, able to, after they've been treated, remain in remission for, years to come. And the biggest thing to kind of implement that is trying to promote a really strong immune system that can handle the infection moving forward.
No, I think that's good. I think, to be clear, I think we missed or overlooked a basic point that would be a frame of reference for patients using our protocol. How do we know, and the title of the talk is how do we know we have success? So for many years, I've used the concept of having 2 weeks of remission and consecutive cycles. And if we can see that, and that tends to occur in the latter part of the year. So if our patients can go on therapy and they're having less reactivity, or even if they're having more reactivity, if they can show me that, I had 2 weeks in a row where I wasn't broad jumping or running hurdles, but I was back to life and I wasn't feeling oppressed or suppressed. If you can do that for 2 weeks in a row, then we know that we pretty much have a good immune situation, and you can get into less therapy and go to maintenance. But that has worked very well. That's been very reliable. I did have another question about how do we get psychiatrists to get on board? Honestly, they've been one of the most cooperative groups in medicine. So we've enjoyed working with many psychiatrists. Sometimes we write our own psychiatric meds and support meds, and sometimes if we have a psychiatrist on board, we defer to them or work with them, and most of them have been most cordial. And I think the reason for that is discussion and dialogue. I think that a good psychiatrist will actually spend some time talking to the patient, understanding the patient, reading the patient, the body language and so forth. And there's a certain credibility that can hopefully transpire between the psychiatrist and the patient. And in that case, the psychiatrist tends to be supportive because they say, well, this is not mental illness. This is an inflammatory organic illness. And what does that? So advanced syphilis, tumors in the brain and that sort of thing. But Lyme borreliosis is by far the most common cause in today's world. And so we find that I really enjoy working with psychiatrists. I mean, we're constantly learning from them, and I think they learn from us. And sometimes we do all the psychiatric meds quite successfully. And if we don't or need help, we'll ask for help.
Yeah, and I think just to piggyback off of that a little bit is, again, we can sort of start management with psychiatric issues, but if we feel that a psychiatrist needs to be on board, then that's something that we really will advocate for our patients. But if a patient has a bad experience, as a lot of our patients do with different medical providers, then we just encourage them to find a psychiatrist that they are able to work with successfully. And if that takes some time, we can offer support in the meantime. But again, getting sort of a bunch of medical providers on a patient's healthcare team is the best way to kind of address all of these issues in the patient's overall health and well-being. And then another question that we got in was, can overexertion or with running or cycling cause the immune system to weaken and symptoms to return? Any initial thoughts on that, Dr. J?
It depends. Depends where you are on the oxidative stress curve. So if you're neutral or near neutral, doing some detoxification such as through exercise, will keep you square. I have a number of patients who run or bike or cycle, and if they don't put in a good workout, they have a crappy day. And what are they doing? They're detoxing. It's their way of detoxing. And that's even those who follow a gluten-free diet and are getting sleep and so forth. But if they don't do the exercise, because that's the third wing of the basic wing of detox. So detox is 1, no gluten. Number 2, take a modicum of high-quality supplements. And under gluten is, watch other food groups that may offend you. Number 2, I said a modicum of anti-inflammatory antioxidant supplements. And 3 is to sweat. So it can be passive or active. And it can be passive if you get in a saltwater bath or you have a sauna. And if you do that, I would drink some warm green tea before you get in there so you're sweating earlier. Or if you're able, you can actively exercise, which is better because you're moving the lymphatics when you exercise your body, and you're sweating. So those are the 3 principles of detoxification, and so that's why we have patients, athletically inclined, who ride that bike 50 miles. And doc, if I don't ride that bike for 50 miles, I have a lousy day, and so forth and so on. And they've been able to maintain their neutrality and the oxidative stress curve that way. I think I make another comment about our world, and that's what's up with all the gluten-free stuff on the aisles? It wasn't there 10, 12, 15 years ago. What's up with that? I mean, is that a commercial marker for people being inflamed throughout, or is there just a certain preference? And I happen to think it's a marker. And as well as all the supplements, my God, that are being reformulated, recompounded, and putting items that we're familiar with, but just in different combinations, and selling them as, okay, this is the magic capsule for you. So our world is really, I think, chronically ill in a lot of ways, and I think it's reflected in the marketplace.
Yeah, just kind of driving home the exercise point there. Exercise, as tolerated for our patients, is a great way for them to detox. I have had patients who maybe overexert themselves and are feeling it the next day, which, depending on where they are in treatment, can cause, maybe some extra stress on their body or symptoms. So the biggest thing there is just knowing your limits, and exercise is always good, but knowing, if you're pushing too hard, is that going to cause you to be really exhausted the next day? Maybe, do a lighter workout or do a little bit less, so that you're not pushing yourself too hard.
That's a good point. I'm sorry if I didn't make that clear. Danny, thank you for bringing that. Yeah, you can't overdo it. So if you exercise and you pay the price, you're not ready to do that particular form of exercise, or to that extent that you're doing. That's too much. So we always ask our patients, how much are you able to do? That's part of our intake, is how much activity can you do before you wipe out, for example, or do you wipe out? And if you're the example that Danny was describing, and that you do too much and you wipe out for a day, you're not doing yourself any good. You're not doing yourself any good, because it has to be a net positive in terms of getting rid of the lactic acid and getting rid of all that, but versus the and having endorphins come out versus the toxins that you are going to liberate otherwise, to pile on top of your pre-existing abnormally high toxic load. So moderation to start with, and if people can run 50 miles and they benefit from it, I'm all for it, but it has to be individualized.
All right, and the next question that we have is something related to muscle twitching. We have a patient writing in saying they've been diagnosed with benign fasciculations, and inquiring whether that is due to the infection, will it go away, etc. I feel like we could do a whole separate live stream on diagnoses that our patients have been given that are likely due to or contributed to by Lyme, and benign fasciculations is one. I do have plenty of patients who come in with that diagnosis, and typically through treatment they do improve. That symptom does eventually go away if it is due to Lyme, but again, we need to do a thorough diagnostic evaluation to make sure that that's really what's playing a role. Anything to add with that?
Yeah, so fasciculations are fine motor movements which are derived from the spinal cord, so the peripheral nerves. If you have clonic jerks or dystonia, where you're just having major spasms and jerks, that's from the limbic system, that's from the brain. So clinically that helps us distinguish where the problems are. And obviously there's often overlap, and mostly there's overlap. So people can certainly have both, and usually do.
All right, and the next question that we got was, can a brain MRI be normal even if you have infection? And in short, the answer is yes. Oftentimes I would say our brain MRI is normal for my patients, although sometimes there are some non-specific findings on the brain MRI that we see a lot with our patients. But to answer the question briefly, yes. Any other thoughts, Dr.
Well,
J?
yeah, I mean, yeah, I've been saying for years, I try to say it in the kindest way possible. Mr. Walters, your brain MR is normal, but that doesn't mean you have a normal brain. And they get that. So, in a sense, it's a bit crude. It's a structural diagnosis or image. So it's looking at the structure of the brain. If it hasn't atrophied, or if they're not demyelinating lesions in the limbic area where the white matter is. So white matter, gray matter. Okay, white matter can be demyelinated, and that's where we see the T2 lesions. We can also see T2 lesions in the spinal cord, demyelinating lesions. So yeah, we need an MR because we need to know they don't have a pineal tumor, a pituitary adenoma, or worst of all, shrinkage, brain loss, cerebral loss, manifested by obvious atrophy or increased dilatation of the ventricles and so forth. But no, I tell the patients, it's, okay, you got a normal MR, that's good, but your brain's not normal.
All right. I think that we've kind of gone through the majority of our questions today. Do you have any other thoughts that you wanted to add or things we wanted to emphasize? I think the big takeaways here, is that progress often is nonlinear, but as long as we're seeing a positive trajectory in our symptom presentation of our patients, then we know, we're moving in the right direction and we're seeing improvement and lowering the infection load and promoting the immune system is kind of our big goals.
Yeah, thank you, Danny. And if the patient doesn't progress, it's on us to find out why. If they've been compliant, we need to double down on what else is going on in their life and see if we can find an outlier there. And sometimes we do. Sometimes it's behind the scenes nasty relationship, for example, something that's unsettling and unhealthy. Sometimes it's an emergent condition such as subacute cholecystitis or gallbladder disease. Sometimes it's unresolved pelvic inflammation through endometriosis. Sometimes it's a misunderstanding of how the patient's sleeping and that they're actually not sleeping as well as they need to have restorative effect. So it's on us, and we look at the roadblocks, and we just start though by asking, okay, what's different in your life? What do you think is causing the slowdown here? Maybe it's an absorption problem. So there are many factors that go into it, and it's our job to double down and sort of look at that and see if we can solve that problem as the patient goes along, if they've been compliant, because we know that our treatments work for the vast majority of patients, but we know everyone's different.
I think that was a great comment to end on, and sort of just focusing back in on the patient. I think that's the most important thing that we do, because we are learning about this disease all the time, is sort of listening to our patients and gathering information from them and working with them to try and get the best outcome possible. But I think that kind of is what we're going to be discussing today. So thank you everyone for attending, our live stream today. It was great getting questions and meeting you, I guess, officially, since this is my first one. So thank you so much for listening.
Well, thank you, Danny. Danielle Adams did a wonderful job today. I'm pleased to have her on staff. She's a marvelous provider, and she did very well. I think you're kind of a natural at this, but delighted to have Danny on board and do this live stream for you. And our next live stream will probably be in January, I'm thinking. So everyone have a happy holiday. We love you, and take care. Bye-bye.